Because we're Health Data Research Network, what do we do? Well, we do a lot of research, and you've seen it online, you've seen it in journals, and most of us are probably involved in the field. Costs a lot, difficult to recruit and find individuals that from which we will learn. Because of the first 2 points, there are very little replication. So we find it once, we say, well, that's gospel now. No problems with statistics, no problem with validation, it works. And we do way too often, except if you go to HDRN, piecemeal data access. And the issue is, it leads to problems with pertinence. I kid you not, I have a village not too far from Sherbrooke, about 20 minutes away, Stoke, about 2,000 people. Someone came in and tried to sell the family physician there a tool to help them decide if a patient has tuberculosis. Now, the person was based on science, had the surveys and the papers, and everyone was like, yeah, but why? Why? No one could remember when was the last time, if there was ever, a case of tuberculosis in that small neighborhood. And then, yet they wanted to expand resources to put that digital tool, and AI or not, in that place. And so it leads to care from incomplete information, incomplete knowledge, and suboptimal care. And when I'm talking about care, it's not only in hospital, it's not only with your physician, it's tool that you are using. It's your smartwatch, and it's all the other devices, if you're diabetics, if you have heart failure, that are based on research that is high quality, but not always pertinent. And when we talk about health data, we tend to talk about research and epidemiology and drafting papers, but it goes a while. Like, for example, you could actually do auto feedback. I'm a physician. How am I doing with my patients with diabetes, for example? Am I treating them properly? I'm a patient. Am I controlling my glucose correctly, my carbs? Do I need decision support? Yeah, but I want to control my carbs, but now I have these options of meals. What should I pick? And it goes down to the right-hand side, obviously, to research and dashboards, because we also need to get the system working and we need to manage it. So we get all of these, and until now, my assertion will be that we've been treating them separately. We have research people, management people, care people, and somewhere, usually absent of those slides, are patients and their families and their caregivers, and they're nowhere. My assertion here is that we deliver a lot of care. Could be at home by the patient or a family member. That today generates a lot of health data. Think about everything you're sending to Apple or Google, whatever, pick your poison. And today, when you talk to researchers, what they say is, we need data. We need data. We want data. And so we can indeed use health data, and that's the basis of the learning health systems. If you base your research on data naturally generated by the system, your chance of being pertinent will be much higher, because you would not work on tuberculosis and Stoke. That data does not exist. So you're doing it, and you end up with research data. Now, there's an arrow there, because this is extremely important. People tend to put AI there. But that's one way to do it. Well, we need to move and cross the gap between research data and knowledge. And I'm sure people in the room know this is quite different. And I'm going to talk about HDRN. The day is called Data for All of Us. I'd like it to be knowledge for all of us. Data is just an intermediary to make it to knowledge. And then the big thing, my biggest pet peeve, and something you should ask anyone coming to you, is how do you affect care? I'll give you an example. We published just before COVID, we developed a model to predict mortality, so the chance of dying if you're hospitalized. We did it with data in Sherbrooke, works very well. We wanted to do it to give patients options to choose their care, knowing what the next year might be holding for them. Now, took the data, with ethics approval, did the model, published it in a very nice journal, and it made it to my CV. We're here. Now, the question you should be asking is, how many individuals were helped with that research? And the answer is going to be 0. Way too many research ends up on my CV and every other people's CV. We get more funding and then there are no impact. Why? Because the system is based on a half loop. Today, what are we funding? We're funding research projects. Well, the research stops at the knowledge. You generate the knowledge, you put it in the journal, and magically the world will be better. And what worries me is that this is what we sell to the patients. This is what we sell to individuals. Give us your data because we're going to make the world better. And oftentimes what we're making better is actually our CVs. So my first conclusion I'd like you to think about is we tend to do research and then care and knowledge transfer. So all the tooling and the publishing and everything, we tend to deal with them separately. But in the end, everyone has the same requirement: understanding an individual through his or her own data. That's it. So if we want to scale, if we keep taking them in separate silos, that will never work and that will not scale. Information and so data is in many places. Obviously, primary care hospital health industries are a very interesting place where the laws of physics seem to break or at least work in different ways. But we also have data in cohorts, randomized controlled trial, biobanks, and Excel spreadsheets, and it's time for another sad story. So I play doctor once in a while, about 1 week in 4. I was taking care of a young man, 55. I'm going to say young because otherwise, yeah, I'll say young. Colon cancer, had chemotherapy, had a bad side effect. It's like if his skin was burning on his own body. Stayed in ICU for the longest time, months of readaptation. Actually made it through, thank God. Now, you could say, and you could look at the data before and say, well, bad luck, side effects happen, that's it. But what I was to tell you that this gentleman participated in a biobank in the same institution 3 years before. And what if I was to tell you that this whole genome was sequenced? And what if I was to tell you that if you have the genome, you can predict the side effect? And I'm going to ask you a last question. What if I was to tell you it was your brother, your father, or your son? That would personally infuriates me. And the answer I got, oh, but that's research data. We're giving care. This is dirty data. And I almost blew a gasket. I was like, we can't see these things separately. The fact that it was collected somewhere else does not justify a poor man going to the ICU when it was entirely preventable. But to go back to broader health data, if I have a Fitbit or a smartphone, I can tell you if you're active. Actually, that's a key question when I'm seeing patients. When I'm asking, are you active? If you say no, then you tell the truth. If you say yes, that's 8 out of 10. Now I need to find the liars. If I have your watch or your smartphone, it's much easier. And you don't need new gizmos. We have colleagues in Toronto using smart thermostat, and they have a mobility score because the thermostat knows when you're passing by. And they're now starting to predict if you're going to go to the ER using the thermostat that's already in your house. And lastly, but as important, what is your access to urban resources, smog, pollution, and active transportation options? And those are essential. And again, I don't have access to this as a physician. Same individual, same diabetes, same genes, same pills. You live on a street corner where it's busy, no bike path, no bus station, and a McDonald's in front. Take the same individual with a bike path, a bus stop, and a fruit shop in front, and you get two completely different stories. And yet, this is information that we do not take into account. Why? Because it's in a different ballpark. It's geospatial information, and magically, we should just disregard it. So what's important? I think this is all of this. We need clinical data, obviously, but we need environment, because we know that if you have a bike path or a multi-lane system, your heart disease is lower. We need, I think I've convinced you, I hope anyway, research data, also quantified self. We know that patients at home with a scale, when we give them the opportunity to adjust their meds if they have heart failure, so they put on too much water, they do better. And there is a clear link between medication adherence and marital status. And we've known that for a long time. Now, I won't go into which way that goes, because I'm married and I intend to remain so. I got a minimal survival instinct. Now, what we've been told and what you keep hearing is we need your data. But let's think about it. We want to do data at scale from a province perspective, or even a nation's perspective like Canada. What is the likelihood that all of this data for every single Canadian will be in one location? I will argue that technologically, it will never work. In terms of resources, it won't work. And imagine what the target it would be for anyone wanting to get at that data. So we have an opportunity and a challenge. Lots of people need similar things, understand an individual through health data. And we know that putting it in one place will never work. Not only that, if you hear people around you, they'll tell you, oh, I need the data, but I also need the data. So it's not only to get it all in one place, it would be to get them all in many places. That will not fly. Now, in every presentation I do almost, I put this, and I think this is essential, that we don't focus on technology or epidemiology or mathematics. Ethics, legal, and social aspects are essential. We've done surveys and focus groups in Quebec. And as of now, it's a deferred consent. So the way it works in Quebec is if you want to do hospital data, and I think it works in many places like this, we don't ask you. We assume that you gave your you transferred your consent to someone in the hospital that's going to look at the project and say, yeah, I think it's good, or no, I don't think it's good. It's not good. What's interesting on that slides are twofold. If you inform people of what's going on, even if you don't give them direct consent, health data research becomes more acceptable. They're more trusting and more willing for the system to use health data, even though they still don't have direct consent options. The other thing is delegation of consent to a third party. If you look at the red bars, people don't like that. When we tell people this is the way it works, more than half the population is against it. And we're in a pickle now, because this is the way it works. And when you ask people, they're not happy about it. This is something that can go wrong very quickly. It's not the topic of today's presentation, but if you want to search, there are things like meta-consent that have been developed by the Danes that can bridge that gap between we need to have you ask you every single time and you having a say in how your data will be used. So all that to say, technology, mathematics, data, essential, ethics aspects, social acceptance, and legal aspects are essential too, because otherwise we end up with great tools that just do not fit in our society, and they don't get deployed. So how can we support, how can we wrap this into a solution that actually works? So we have at the bottom different types of usages for health data. Audit feedback, so I'm a physician, I want to know how I'm doing. I could do a research project. I could be a patient monitoring my own glucose or asking consultations electronically. And you get data sources, so data that are on your watch, quantified self, administrative data, genomic cohorts maybe, and in your health system. Now, Everyone at the bottom will want its data set in a very specific, pampered way because this is how they want to do. They want to use a specific technology. And if you're an EMR, a hospital, and you get all these people coming at you and say, oh, I want my data this way or that way, it becomes unscalable. And in real life, this is what we're getting. The first one was a big ball of spaghetti. The reality is, the EMR is going to say, all right, I'm going to support monitoring and audit feedback. Research, sorry, no more resources. You're out of luck. E-consult, well, you're going to get admin data and no clinical data because we don't want to play ball. And then that becomes useless. So you pit everyone at the bottom fighting for the resources and the attention of people having the data because they want a copy. How can we do differently? Well, we need a common infrastructure. Where have we seen this in our society? Roads, whether you're in Quebec, well, they might be a bit more bumpy, and then you get to Ontario, it's pretty much the same thing. Water. If you're doing some renovation at home and you need a fitting for one of your pipe, did you ever think, oh gosh, what did I use for the pipe? Because I need exactly the same company to fit the same fitting. No, you don't. Everyone agrees on how the pipes work in the plumbing system. Same with electricity. You don't need the same company to make your electrical wire from your outlet, and yet it works. We have shared expectations, things that are predetermined, not everything. Clients are confident that this will work. And the important things, it's still supporting innovation. If you're telling me that there are no innovations in water and electricity, we need to talk. Now, roads, maybe there aren't that much innovation in roads, but still, it's the same thing. If you have shared expectations for key parts, everyone can innovate around it. So, I'm going to ask you to look at the fact that the consumers at the bottom and the people with data at the top, it doesn't look like a bowl of spaghetti now. There are ways so that we can translate, all the green pieces are translators. We can translate data. So if you are an EMR, electronic medical record, and you are to give and offer data for insights, as we're going to see, as it may, you do it only one way. You don't need to do it 10,000 different ways. And then after the translator, it's always the same way. And if you're a consumer, you don't need to think, oh, wait, is this diagnosis coming from the EMR or a research cohort? After translation, you will still be able to consume it. So if we ask everyone to do one-on-one translation, it doesn't work. And that exists. Shared, decentralized because there's no single point, distributed because everyone can work in parallel, infrastructure is required and actually exists. And what does it allow us to do? I think this is key here. What we've been doing until now is we want every piece of data to go into one place for the analysis. And now we have specific delicate places where we have data, for example, Statistic Canada. Now, they won't place it in one place. And we have provincial centers, we have CAI, we have other places, other organizations that will say, well, I cannot get my data out of my own organizations either. And so it's, oh, but you should give it to me. Oh, no, you should give it to me. Oh, give it to me, I'm going to do the analysis. And it's a deaf conversation that goes nowhere. Why? Because of two wrong assumptions. A, we need the data physically in one place, and B, that's going to be scalable. It's not going to happen. And my question is, why do we insist on doing things that way? We know and we saw it's unrealistic. When we go at scale, not doable. But I think it's a case of old habits die hard. People have been doing it for the longest time. Researchers are trained to have their own lab in their own organization, collect their own data, and produce their own paper. And that just not work. And the good thing is there is another way. Now, the silos that we were talking about, and you've heard before, we need to break silos. We tried. I'm saying, why not? My assertion is maybe we don't need to. Let's keep the data from BC in a silo. That's fine. Let's keep Quebec data and MIN data. ISQ is l'Institut de la Statistique du Québec, so statistics and MIN statistics, and genomics data too in its own silo. That's fine. And what if, instead of bringing everything at the bottom, we were saying part of the calculations will be done to the left, part of the calculations will be done to the right, the final calculation will be done at the bottom, and in the end, we get the exact same answer we would have had if the data was copied once more to the bottom. And this is what we call distributed analyses. So the key here is the data in BC and Quebec is not moving, and what we are moving and sharing are insights about that data. The data stays there, we don't need to move it, and we get exactly the same answers we would if the data was sitting on your own machine. So I wanted purposefully this presentation to be very high level, given the backgrounds from the different backgrounds in the crowd. So I'll be very happy to take more specific questions on any parts. But if there is something I'd like you to remember is we do not need to move the data so that we as a community can share insights so that everyone benefits from them. We have the capacity, we have the know-how, we have the science to analyze the data in place so that it is scalable, acceptable, and we get to the bottom line, which is working together so we can all together improve our health. So I'm going to leave you with this last slide. When someone comes to you and says, Apple, Google, a researcher, another organization, can I have your data? You should actually ask them, do you really need my data? Or can I instead contribute with others to share common insights so we can all do better together?